Good Sunday morning. Hey, Pink Meadows, how are you? It's a rainy Sunday morning here in Columbus, Ohio. I thought I'd jump online and see if any friends were out and about, if anyone might want to chit-chat this morning. Unusual Numb Limbs is there. James is there. What's up, Marilyn? How are you? Hello, Eve Monster. Excuse me, Eve Mosher. Luca's in the house. Maggie's here. This is great. Look at this, guys. Cracker Barrel fans in the house saying howdy. Fatima's in the house. This is great. Look, we got folks from Chicago, folks jumping on from Connecticut. This is fantastic. Ontario's in the house. Scotland's in the house. Hello, Jen McGraw. It's great to see you today. We've got one of our moderators online. We've got another moderator, Angela from Chillicothe. This is superb. Hello, Ren from Italy. Carolyn Strand is from the UK. Looks like there's plenty of folks online this morning. Hello, howdy, hi, everyone. MS Nurse from Nashville, what's going on? Hello, hi. Hello, Susan. Maggie, it's great to see you. Life with Lou, Denver, Colorado in the house. Australia in the house. This is great, guys. Erica R is in the house. I'll tell you what, guys, there's plenty of us already online. Let's just do it to it. Let's give it just a few more minutes, see if anyone else wants to join us. Jennifer is here from Louisiana. Paul is here from Fostoria. Kathleen waving hi. This is fantastic. Cliff, you know it's always coffee for me. Good night in Australia. Oh, I guess it is the other side of the world. So James asks a question. How's your coffee prepared in the morning? That's a great question, James. I'll tell you what. Let's jump into a live stream and we'll talk about it, shall we? Howdy! Hey, hi everyone. Aaron Boster here. It is Sunday, April 30th. It's kind of a rainy Sunday outside today. I've got my coffee in hand and I wanted to jump online and just do an impromptu Ask Me Anything MS. Spend a little bit of time with you guys this morning. Kind of warms my heart. Doug Tagg, one of our amazing moderators, is here. What a great Sunday morning surprise, he writes. Much better than starting with a Cleveland Plain dealer. Thank you very much, Doug in hand. Coffee is right here, my friend. It's great to see you. Thank you for being here today. JT's got some blueberries in the morning. Marilyn is saying, anyone in Oklahoma would you recommend for seeing an MS? Gabe Pardo is out your way. Gabe Pardo is about as good as they get. Oh no, it's Ellie, says she loves the purple. Well, thank you very, very much. This is actual Boster, let me see if I can find it. Boster MS Center swag. So this is actually gear from the Boster Center. Good morning from Spain. This is fantastic. Question here, recent blood work. My white blood cell and red blood cells are both low. Is that common in MS? So Jennifer, no, that's not common in multiple sclerosis, but some of the medicines that we use to treat MS can lower the white count. We generally don't expect to see a red blood cell count drop, and there are some side effects that we can see in the setting of MS medications, which could cause a drop in counts. So if you're having a drop in counts, that's definitely something that you're going to want to speak to your doctor about. They may need to do some other investigations. But no, that's not normal in MS. It's not something that we would expect to see. Now, I've got a screen pulled up here. You guys can't see it, but I'm trying to chase down a web address that I want to share with you. Here it is. Let me get there. I've almost got it. I feel very sneaky behind the scenes here. Here we go. Let me just copy this into a ditty so I can share it with you guys. All right. I think I've almost got it sorted here. Let's go to the chat and paste. All right. So I put a link here to the Boster Center newsletter. Let me see if I can do a better job of that. Let's see if this works better. All right. Can you guys see that link? So if you would click that link, not on the screen, but in the chat, it will take you to something very exciting. It's called the Boster Corner. And the Boster Center for MS has started to put together a monthly newsletter. It's kind of an encapsulation of my YouTube videos, any other events that I may be participating in or attending, any Congress updates, things like that, but also things that are going on at the Boster Center for MS, clinical trials that we're enrolling for. It's kind of just an up-to-date newsletter of everything that's happened in the last month. So you don't have to be a member of the Boster Center. You don't need to be a patient of mine in order to receive the newsletter. If you would like to stay up and current with what's hot and happening in MS or what's hot and happening at the Boster Center for MS, definitely click that link, please, and check it out. It gives you an opportunity to leave your email address, and then you'll be on the subscription mailer, and we'll send you out a monthly newsletter. Of course, if you don't like that, then you can always unsubscribe. So I was excited to share that with you. It's something that my team's been working on diligently for several months now. It's currently available, so I'm really excited about that. Thank you. Here's a really great question from Christian. Let me see if I can get the thing to pop up here. So Christian writes, do you think that we'll be able to switch between BTK inhibitors once they're approved, like you can between Ocrevus and Kesimpta? So that's a good question. When you make a medicine, which is kind of like in a certain class, you could use an analogy of a car. So you have a vehicle, the vehicle type is a car, and a driver of a car can switch between cars. So similarly, if you're a person who is taking a BTK inhibitor, hypothetically, you could switch to a different BTK inhibitor. I don't see a reason medically why that would be a no-no, unless you had a risk with a BTK inhibitor, like it caused a side effect that was dangerous to your health. We might see that throughout the class. For example, it's very likely that people that have liver injury, if they have liver damage, like if they have a liver problem that could be worsened by medicines, BTK inhibitors are processed by the liver, and we may use a careful hand when starting that particular human on any BTK inhibitor. We can think of it as a class, and you're right, I anticipate that you'll be able to switch within the class once these drugs are available. I've got a hello, howdy, hi from Greece. That's pretty fantastic. It's always amazing to me just to participate in this village. This growing global online community, it just warms my heart. So thank you very much for jumping on. That's really, really awesome. Let's look for some more questions. So Stephanie asks, how important is the thyroid? So that's a great question. So the thyroid is part of your endocrine system, and it lives up here in your neck. And it's very important in regulating a lot of homeostatic processes. What does homeostatic processes mean? That's a really big word for a Sunday morning. That's like a Scrabble word. It means controlling like your temperature and your metabolism and your internal kind of barometers of things. And when the thyroid is out of whack, you can have thinning hair. Obviously, I can't give you an example of that because I don't have a prop to share with you. You can have elevated internal temperature. You can have trouble sleeping. You can be anxious. The flip side is if the thyroid is low, you can be lethargic. You can gain weight. You can have thick and coarse skin and hair. And so the thyroid is very important in my opinion. Now, something that's interesting is you don't need your thyroid to live as long as you can supplement it. So there are situations where someone loses their thyroid. It either dies or we actually kill it because it's misbehaving. And then we can supplement with thyroxine, which we can actually take pills that are the hormones that the thyroid would otherwise supply. So one of the most potent MS medicines that exists is called Lemtrada or alemtuzumab. And it is, in my opinion, hands down the most effective medicine that I've used to treat multiple sclerosis. But there's a 41% chance that it will take out your thyroid and that it can cause a thyroid autoimmunity. So when someone signs up to take Limtrada, they have to accept a 1 in 3 chance that they may beat up on their thyroid and then have to take a pill to supplement it. That's a good question. So here's a question from Samir. Hi, Dr. Boster. Well, hello, good sir. I'm in Australia. To get my visa, I might need to change medicines from Ocrevus to Rituxan. Do you see any risk? So I'm not sure I understand the part about the visa, but let's just take the question of Ocrevus to Rituxan because that's something I can comment on. So switching from Ocrevus to Rituxan is really easy. It's like if you were drinking Coca-Cola and you switch to Pepsi-Cola, you might not even notice it. The medicines are more similar than dissimilar. They're both infused in the vein. They're both given every 6 months for MS. They both take just about the same amount of time to run in. Ocrevus can be given a little faster sometimes. Rituxan is a little less well tolerated. And so the nurse needs to be a little more attentive when giving rituximab because sometimes people can have more infusion reactions. But otherwise, as far as the efficacy of the two drugs, I wouldn't expect big changes. And I think going from one to the other shouldn't be terribly difficult. All right, I'm trying to figure out where I left off in the questions. If I miss your question, please don't be offended. I go back through the chat and I take notes, and I use these questions to develop other YouTube videos. So let's see how many people have joined us online. 75 folks, that's awesome. Thank you guys. There's 75 of you that have joined me today impromptu on a Sunday morning, and that's really awesome. Thank you very, very much. All right, let's answer some more questions. Alex is here. Is there morning blood monitoring needed with Ocrevus? Is there blood monitoring needed with Ocrevus? Limtrada was like clockwork. No check since I moved out. All right, so what monitoring needs to happen is very drug specific in MS. So for example, if you're taking Copaxone, then we check no labs. If you're taking interferon beta products like Avonex, Betaseron, Extavia, Plegridy, all those medicines, then there's a set of labs we check. And those labs are different for every single medicine that we take. Now, Ocrevus is really interesting. Ocrevus is not metabolized, it's catabolized. So you've heard the word metabolism before. That's where an organ in your body breaks down the drug. And so oftentimes medicines are metabolized by either the liver or the kidneys. Ocrevus and B-cell depleters are not metabolized, they're catabolized with a C. Catabolism is where the drug dissolves in your bloodstream. And so it's not processed by an organ. Now, because of that, we don't need to check liver enzymes or kidney function when we take Ocrevus, because Ocrevus doesn't really impact that. What does Ocrevus impact? The white blood cells. And so it's reasonable, at least at my center, we check some labs at the time that we draw, we get the IV set up. So twice a year, my patients come to see me in clinic. And for Ocrevus, they get an infusion in the vein. And when we stick the IV in, we draw some blood and we check some things. We check a white blood cell count and we check the lymphocyte count, which comes with it. And that teaches us about the impact of the Ocrevus. And then we also will check some immunoglobulins, which is to look for antibodies to make sure that the Ocrevus hasn't by chance pushed the antibodies down too far. So those are labs that I like to get twice a year during the Ocrevus infusion day. I don't want my patient to have to come back separately. Now, Limtrada is very different than Ocrevus, and Limtrada has a lot of different potential side effects. Limtrada has so many different potential side effects that the American FDA created what's called a REMS program. REMS stands for Risk Evaluation Mitigation Strategy. It's a mandated program which mandates that people that receive Limtrada get blood drawn and urine drawn once a month for 4 years after their last dose. Why? Because we have to check the thyroid, we have to check the liver and the kidneys, we have to check the blood counts, and there's a lot of monitoring that goes on. And if someone signs up to take Limtrada, then they have to agree to do that monitoring to keep them safe. So big differences, but the take home here is each individual drug will have its own set of laboratories that needs to be monitored for to make sure that we can keep that person safe while on that drug. And if you switch from drug A to drug B, you may have a different set of monitoring. Interestingly, when you're picking an MS medicine, the monitoring matters. So in this example, Alex, signing up for 5 years of labs is a lot. And I have plenty of patients that are willing to do that, and I have plenty of patients that absolutely would not want to do that. And so the monitoring factors in, it certainly does. So Cliff writes, sorry, totally distracted by that thing that looks like a mid-century machine behind you. Yeah, it does. So it is a mid-century machine, and I don't want to deconstruct the whole situation here, but maybe I can show it to you really quick. Let me see if I can figure out how to do that. This is a platen press. My ex-wife is an excellent graphic designer, and she left that behemoth of a machine in my house. It actually works. It's a fully functioning platen press. So I'm going to stick with my day job as an MS neurologist, but just to show you guys, this behemoth machine works really, really well. And in the years past, I've seen her actually print on it. So that's what it is. If somebody listening is interested in a platen press and you want a 2,000 pound thing shipped to your house, let me know. Maybe I can send it to you because I certainly don't use it. That's really funny that you saw that. Thank you for asking about it. Melody says that she finally made it to a live stream. Well, thank you very much for being here. I try to plan one live stream every month, the last week of the month. I try to make sure I can get on and answer questions and oftentimes deliver some educational content. I haven't done an awesome job of planning those, but if you sign up for the newsletter, then let's see if I can show you that. If you sign up for the newsletter, then it will tell you when we're doing each live stream. So that would be an easy way to make sure that you catch the live streams just by signing up for the newsletter here. Click that link and then fill out your email address, and then we will literally mail you a newsletter, every month, updating you on when I go live. Today, I just really wanted to spend some time with you guys, and I'm so appreciative that there's 109 of you that have jumped on from around the world so that we could hang out and talk a little bit about MS. Thank you for that. All right, let's see what else is rocking and rolling here. Let me find another question. So here's a question from Rose. I just saw my neurologist, and she asked, why am I not on a disease-modifying therapy yet? She said, depending on my MRI results I had this week, it's only, let me see. So what I'm taking from this is Rose was interacting with her neurologist, and they weren't sure whether they were going to start a disease-modifying therapy. Now, Rose, I don't have enough information from those 3 lines to really weigh in. What I can share with you is if you have a diagnosis of MS, I want you on an MS disease-modifying therapy really badly. If you don't yet have a diagnosis of MS, I can understand there may be a discussion about when we pull the trigger. But obviously there's a lot of factors there that I don't have in front of me. So how important are thyroid levels when dealing with MS? As I mentioned a little earlier in this live stream, thyroid is important, and the MS doesn't impact the thyroid, but MS medicines can impact the thyroid. What causes a gait where you lean to one side when walking? So, oh no, it's Ellie. That's a great question. So walking is extremely complicated. There's a lot of factors that are involved in walking, and maybe I can demonstrate some walking to you today. Why not? Let me have a sip of coffee and I'll clear a runway, and then we'll talk about walking. So let's see here. I want to make sure I don't step on my dog. So if you can see me, I don't know if you can see my legs. Let's see, I can change the live stream a little bit. We'll put this up here so that you can see my legs a little bit better. All right, so here I am. Now, when you're walking, there's a lot of different phases to walking, okay? So one of the things that we have is we have arm swing, and the arms act as a counterbalance. So when this leg goes forward, this arm goes forward. So that way I'm counterbalancing like this. And so we can look at arm swing when people are walking. So if I see somebody walking and they're walking like this and they're not swinging this arm, then that tells me something about their gait mechanics. Similarly, when someone's walking, there's a lot of different phases to heel strike. I don't know if you can actually see. I bring my knee up, and then I swing my leg, and then I strike my heel on the ground, and then I turn over, and then I push with my foot. And so you can break down the mechanics of gait into each of its component parts. I'm going to sit back down because I don't know how well you're actually able to see my movement. But if you have something wrong with the nervous system, it can impact your walking. And it could be anything messed up with your nervous system. So let me explain. When you're walking, your feet feel the ground, and your ankle feels the joint angle, the angle that you're standing at, and it's giving you feedback. If your sensory information is goofy, in other words, if you have a numb leg, you're not getting that sensory feedback. And so it can change how you walk because you can't feel the ground. If you have spasticity, where your leg is stiff, maybe I can imitate that. So if you have a stiff leg, so let's say that this leg is stiff. It doesn't bend very well. And it'll change how I walk. Because if I can't bend that leg, then I'm going to limp when I walk. So I can't bend the leg, so I have to swing the leg around like this. And it's changing the gait mechanics. If you watch that again, watch this arm. So naturally, I end up holding this arm out over here because I'm trying to counterbalance. And so just being stiff in your leg can change how you walk. If you have what's called ataxia, so ataxia is a doctor word that means off balance, then it can impact the way that you walk. So if you look at my walking right now, I'm narrow stanced. All right, so when I'm walking, I'm very narrow based. My legs are pretty close together. But if I was a little drunk, right, and I had to spread my legs out really wide because I didn't have my sea legs about me, right, so I would have some stumbling. Now you can see that at a bar at around 2 in the morning when someone's been drinking too much, but unfortunately, you can also see it when someone has cerebellar involvement of their multiple sclerosis. Now, we haven't even got into weakness. So if you have a weakness of a limb or a weakness of a particular muscle, that can change how you walk. So let's pretend that this leg, my hip flexor here, I'm trying to get in the camera, my hip flexor here wasn't strong. So I had trouble picking my leg up like this. So when I'm walking, I might have to slide my leg on the ground. And you can imagine that if the ground was uneven, it could grab my foot. I could tumble. So there are a lot of different factors, neurological systems, which impact your ability to walk. And oftentimes when the neurologist sees you in clinic, they may ask you to walk down the hallway and back. That teaches us a tremendous amount of information because we can learn about your sensory systems, your motor systems. We can learn about spasticity. We can learn about balance just from watching you walk. It's very, very helpful. I actually have several YouTube videos on this channel I've done on walking. So if you do a YouTube search, you can see several videos that I've done on walking for MS. Now, before I take another question, I just realized that I don't have my computer plugged in. Shame on me. Let me go grab a plug. Otherwise, we might suddenly collapse when the power runs out. 1 second. Please don't run away. There's 116 of you that have joined me. Please stay on the line. Don't split. I'll be back in seconds. I'm just behind the computer plugging it in so that we don't lose power. All right. Now we are all powered up and I'm feeling much better. Let's look for another question. That was a great one. Thank you for asking that. So Shannon Pearson writes, the coming of BTK inhibitors, which one are you most excited about and why? So that's great. So as some of you who follow the channel may know, right now I'm involved in many clinical trial investigations, trying to bring the latest and greatest, newest drugs to the market so people in Central Ohio can take them. And there are several MS companies that are all developing BTK inhibitors. So Novartis has a drug called remibrutinib. I didn't make up these names, by the way. And Serono has a drug called evobrutinib. And they're funny names. And Sanofi has a drug called tolobrutinib. And Genentech has a drug called fenebrutinib. And I'm involved in investigations with all of them right now. And we're studying them in different kinds of MS. We have a couple clinical trials looking at relapsing multiple sclerosis, the most common form of MS. We have a couple trials looking at primary progressive MS with BTK inhibitors. And we have some trials looking at SPMS with BTK inhibitors. Now, Shannon's question is, which of all those molecules am I the most excited about? And right now, I don't know. And the reason I don't know is these trials are actively going on right now. So right now, people are signing up to participate. They're enrolling into the trials. They're receiving study drug, and we're running them through the rigor of the clinical trial. When we get our final readouts, then we'll be able to start to tell the differences in efficacy, safety, tolerability. We'll be able to understand the differences of the impact of the drugs on the specific MRI measures and on clinical measures. And that's when I think that we're going to start to be able to try to compare the drugs together, or one against the other one. Today, I don't think that we have enough information to really guide us. Now, there are differences amongst these drugs. Some of the drugs are reversible, some of them are irreversible. So the way that they affect the BTK inhibitor is different. Some of them have more penetrance into the central compartment, some of them have less penetrance in the central compartment. And right now, we don't know which is going to make for the very, very best combination. So please stay tuned. I am extremely excited about the class as a whole, and I'm very, very excited that we at the Boster Center for MS can participate in this research because I think it's pretty groundbreaking stuff. Martin is from Germany saying hello. Guten Tag. So Heisenberg says, I have a sibling with MS. The neurologist talked about environmental factors, but what exactly from our environment could cause it for both of us in very different periods of time? So that's a great question. That's a question really getting at the heart of what causes MS and what are some of the environmental factors that may play a role. Now, I am going to refill my coffee, and I'm going to hope that 131 of you stay put for just 1 second while I heat my coffee up. Now, someone had asked, how do I prepare my coffee? I guess I'll answer that as I fill this. I'll be right back. Okay, don't run away. I hope that you can still hear me. I'm just getting some coffee set up. I should have done that beforehand. Don't run away. I'm almost there. Come on, River, let's sit back down. Come here, River. All right, the coffee's brewing. I haven't lost too many of you. Thank you very much. Of course, I'll have to go fetch it in a second. How do I like my coffee? Someone asked on the pre-show this morning. I drink my coffee black. I'm very spoiled. I have a Gaggia. I have this really, really nice Italian coffee maker. Mwah! It makes amazing fresh ground espresso every morning. You can see my beautiful dog down here. And so that's what I've got in the kitchen right now, brewing. I don't put anything in my coffee. I like it black. Okay, so let's jump into this really, really great question about siblings. So this person shares that both they have MS and the sibling has MS, and the neurologist was commenting on environmental risk factors. So it's not as if there's one environmental risk factor like exposure to blank causes MS. That doesn't exist. We think that there's really probably a 3-step process that leads to someone developing MS. And there's a couple things that you and your siblings share which would predispose both of you to have MS potentially. The first is similar genes. So genetics play a role in MS, not like a traditional genetic condition like sickle cell anemia. If you have sickle cell anemia, 1 in 4 of your kids is going to have sickle cell anemia. So that's a proper genetic condition. Cystic fibrosis is another example of a genetic condition. MS is not a genetic condition in that sense. Here in the Midwest, the average incidence of MS is about 1 person for every 350. Now, if you have MS, your first degree relative, so your mom, dad, brother, sister, kid, their risk is not 1 in 350, it's 1 in 40. So the risk is 1 in 40, which is a higher risk, but it's not a proper genetic condition. So in other words, if someone in your family has MS, then because of genes, other folks in your family have a slight increased risk, which is not enough for both of you to have MS. That's just a genetic predisposition. Then on top of that, we have environmental risk factors. So it's become apparent that certain environmental risk factors can either increase or decrease someone's genetic risk to then go on and get MS. So what are those environmental risk factors? Well, one of them is exposure to pollutants. So like exposure to tobacco smoke, firsthand, secondhand, or maybe exposure to poor air quality. These are factors that might increase a given human's risk to develop MS. Another thing, whoops, I'm getting called here. Let me just tell them that I'm on a live stream. Doing a impromptu live stream. You guys are being really patient. Thank you for that. Now, what are some other environmental risk factors? It looks like obesity increases the risk to develop MS. So if you had 2 children and one of them was morbidly obese and very heavy and the other one was not, the child that was morbidly obese would have a higher risk to go on to develop MS. And so that's another risk factor. What's another one? Exposure to EBV, mono. So if one of you was exposed to mono and the other one wasn't, that might play a very different role. If both of you are exposed to mono, then you might both have that risk factor. So there are some environmental risk factors. Now, it's interesting that the neurologist brought this up because presumably, if your siblings growing up in the same household, you probably share similar genetics if you have the same mom and dad, and you probably share many of the early environmental risk factors. Now, typically we don't see clusters where families have MS. It's less than 10% of the time, but it most certainly does present. I most certainly have families where mom, auntie, and patient, are all first, second degree relatives. So it can happen. That's a great question. Thank you for asking it. All right, let's keep on keeping on and look and see what else we have here. Hi from India. That's awesome. Now, Francine, you have followed this channel for a really long time, and I love reading your comments, and I didn't know that you were in India, so that's really awesome. Hello, howdy, hi. All right. So here we have another question about siblings. Thank you, Doc. Well, you're very welcome. My sibling had MS hug and no idea what that was. Let me just see here. And I figured it out from your video. Oh, that's awesome. So sharing that you figured out about the MS hug because of these videos. Well, that warms my heart. Thank you. I started this YouTube channel in an attempt at educating and empowering and energizing my own patients in between clinic visits, because you may not see me more than once every 3 months, or sometimes only every 6 months. And that's not enough interaction to really up your game and help you live your very best life despite having MS. And so it's my hope that by tuning into the videos that it can really help with the educational process and energize you. And I'm so excited to hear that someone learned about the MS hug through the videos. Yay! So Martin shares, I'm on Kesimpta and I like to know if symptoms go away completely with it. No. So that's a really, really good question. So when you have multiple sclerosis, there's really 3 avenues of treatment that we need to consider. And there are three kinds of treatment that we do all at the same time. Now, before I answer that question, I'm going to go fetch the coffee that I just brewed. So please, please don't run away, Martin. All right, you can time me. I'm going to be Speedy Gonzalez to grab my coffee. Here I go. Don't run away, Martin. I'll be right back. Just like Doug, I've got coffee in hand. Headed back to the screen. Thank you, everyone, for being really patient. And here's the way I like to think about MS symptoms and MS treatment. When you have multiple sclerosis, there are three ways that we want to treat your disease all at the same time. The first one is treating MS attacks. So if you have an MS attack, or if you don't, we don't predict that, right? We don't know if it's going to happen. So we just have to be ready. So if you have a new neurological symptom that lasts longer than 24 hours, you got to holler at your MS neurologist, say, "Hey girl," and then talk about what's going on. You may probably need to come in and be treated for an MS attack. MS attack treatment typically involves steroids or something like steroids to help hasten recovery. And that's one of the three ways that we're going to treat you. And that's just going to be sitting on the side because we don't know when it's going to happen. The second way that we treat you is we treat symptoms that suck. So a symptom is something that bothers you. And I'll give you an example. Let's say, God forbid, that you had an MS attack where the left leg felt like it was burning. And then after steroids and time, the left leg burning died down to just 10%. So you're left with 10% burning of your left leg. And when you're overtired, it's going to hurt more. If you have an infection, it's going to hurt more. You have this constant burning. That has now become a chronic symptom, which is terrible sounding. And so we may give you symptomatic medicines, pills that you take a couple times a day to dampen the burning sensation. Now, treating that burning sensation is treating a symptom. It's not slowing your disease down. It's making the burning not burn so that you can have a better quality of life. And we treat symptoms in MS as they come up. My favorite example, Martin, is erectile function. So men, we love our erections. We're big fans, right? And some men with MS can develop erectile dysfunction. And if a guy with MS has erectile dysfunction and he doesn't like it, I give him Viagra or Cialis. Now, if a guy with MS has erectile dysfunction and he doesn't care, well, then I don't care. Because in this example, treating erectile dysfunction, or in the last example, treating a burning leg, has no bearing whatsoever on the long-term outcome of the MS. It has everything to do with quality of life in the now. And so the second way that we treat your MS after we address attacks when they occur is we treat chronic symptoms. The third way is where the Kesimpta comes in. The third way that we treat MS is we give a medicine to slow it down. Kesimpta does not remove the burning of the leg. Kesimpta does not improve erectile function. I wish it did. Kesimpta is a birth control pill against a future MS event. So we're not taking Kesimpta to treat an attack. It doesn't do that. And we're not treating symptoms like erectile dysfunction or burning legs with Kesimpta because it doesn't do that. You're taking Kesimpta to prevent the other leg from having an attack of burning or from some other MS attack. And so really, when we're thinking about treating your MS, all three things need to be in play. You need to be on a disease-modifying therapy, and we need to make sure it's working. We need to identify attacks and treat them when they occur, and we need to treat chronic symptoms. So you may find yourself on Kesimpta to deal with slowing the MS down and on a medicine to manage a chronic symptom. That was a great question, Martin. Thank you for asking it. Thank you for 145 amazing human beings that have spontaneously jumped online to spend Sunday morning with me. That warms my heart. Voilà, Nicolas, à Paris. Bonjour, ça fait grand plaisir de faire votre connaissance, même si c'est sur l'ordinateur. Ça fait plaisir de passer un moment ensemble et avoir un peu de café. Merci bien. Fabry's disease is a genetic condition which typically affects young people, and one of the hallmarks is pain. I have not seen a Fabry condition confused with MS, But I also don't see a lot of pediatric multiple sclerosis. So Life with Lou says, thanks for doing the chat. Well, you're very welcome. What are your thoughts on hematopoietic stem cell transplantation for someone not having frequent relapses? I've heard conflicting information. So Lou asks a very relevant question about a sort of a hot topic in multiple sclerosis, and that's hematopoietic stem cell transplantation, or HSCT. Now, HSCT is not approved for MS in the United States. Here, I'm going to turn a little background music on. Can you guys hear the background music? I don't want to make it too loud, but it's kind of fun trap music, so we'll just kind of let that play. You can let me know in the chat if it's too loud. So stem cell transplantation is not FDA approved. Here in the United States, the FDA has not green-lighted it to be used for MS. It's still considered something being studied under research. And presently here in the United States, there are several ongoing research investigations studying hematopoietic stem cell transplants to treat MS. Now, in other places in the world, for example, in Great Britain, now the NHS has approved stem cell transplantation for severe multiple sclerosis. And so it is an option through the UK system as something that can be done. So stem cell transplantation is not a medicine. It's not taking a pill to do something. It's a procedure where you murder the bone marrow. You destroy the human's bone marrow and you erase it. So they don't have a bone marrow anymore. Now, if you stopped right there, they would eventually die from infection, which is not the goal. So then we give them back stem cells so they repopulate their immune system so that they don't die. And stem cell transplantation is an effective way of treating MS, it appears, but with significant risk. I will share with you that at the last ECTRIMS meeting that I attended this past fall, there was a poster that looked at stem cell against Limtrada, Tysabri, Ocrevus, and it wasn't able to demonstrate superior outcomes compared to those therapies. So I think that the jury is still out on exactly where the stem cell transplantation fits in, although I do think that it's going to become prime time in the next 5 to 10 years. Fallout writes, how bad is it to have black holes at a young age, less than 30? Well, first of all, Fallout, less than 30 is very young, so I completely agree with you. 30 is like the new 20, my friend. Now, black holes, what are black holes? So black holes are an MRI finding. And when you have an MRI and you have intense inflammation, the white spot is an area of inflammation. If it's intense enough, it can actually eat away at the brain tissue. And what you're left with is a divot, like a hole, literally. A black hole is literally a hole. So what I think of sometimes when I'm trying to explain it to a family is imagine a hypothetical war in a city where there are two sides bombing each other and firing weapons and missiles, and it's really scary and stuff. And when all the dust settles, there's no city left. There's a divot where the city used to be. There was so much artillery fire and so much inflammation in this example that there's just a crater where the city used to be. And that's unfortunately what we can see in the setting of some of MS lesions. And so when you're looking at an MRI with your neurologist and they show you white spots, say, okay, the question is, are there any new white spots? Are there any enlarged white spots? And the answer hopefully is no. The next question is there any enhancement? When we give the contrast dye in the IV, does it light up any of the spots? And hopefully the answer is no. The third set of questions have to do with black holes. Are there any new black holes, or have any of the old black holes gotten bigger? Now, the ratio that I keep in my head is we want about a no more than a 1 to 10 ratio of black holes to white spots. So if you have 10 white spots, I'm going to be okay with 1 black hole. But if you have 5 black holes to 10 white spots, that ratio is very concerning. All people with MS should have black holes. So when I'm looking at an MRI, if I see no black holes, it actually raises my suspicion that maybe it's not MS. It's not a requirement, but it's nearly a requirement in my mind. When I'm looking at someone, I expect to see a couple black holes. Now, the more black holes, the worse it is. And so if you have a lot of black holes, that's more concerning than if you only have a few. The age it happens, theoretically, having any MS activity early in life is less good than having it later in life, and that's just a comment about chronology. But I wouldn't look at a couple black holes on a 30-something scan and think that means something bad in and of itself. So Melody says, I thought natalizumab was Tysabri. It is. So this gets into the way that we name drugs, which is super weird, right? So all drugs have multiple names. There's a generic name, and then there's a brand name. So the generic name for natalizumab is natalizumab. And so if a different manufacturer besides Biogen were to fabricate the drug, it would be another natalizumab, but it may be a different brand. So the company Biogen makes the brand Tysabri. Now, this drug, natalizumab, will soon maybe be available through a generic, and it won't be named Tysabri. It'll be another natalizumab. I know this is really weird nomenclature, so I'll give you a different example. So glatiramer acetate, GA, is the generic of Copaxone. But now we have multiple different brands of glatiramer acetate. So another common generic brand is Glutopa. So Glutopa and Copaxone are both brands of glatiramer acetate. So to answer your question, yes, Tysabri is the brand of natalizumab. And I didn't make up these names. Somebody else did. So KG writes that her 5-year-old recently got mono. What does this do for the risk of MS? We believe that contracting mono is something that 95% of Americans experience, which is a very, very high percentage. So the likelihood that your kid would get mono is 95% just living in the United States. Now, it looks like mono might be a requirement to go on to develop multiple sclerosis. It's not a foregone conclusion. So we can't ungive your kid mono. And frankly, we can't even prevent children from getting mono yet. We don't have like vaccine programs to do that. And so what will we do about the risk to MS? Well, there's other things that you can do to lower your child's risk to develop MS. You can't ungive them mono because we don't know how to do that, but you can make sure that they're physically active and not morbidly obese because those are risk factors. You can also make sure that they are, with their supervision of their pediatrician, supplementing their vitamin D level. Because if we can push your child's vitamin D level above 50, there's some data that suggests that might be protective against MS. Most importantly, we can make sure that your 5-year-old isn't subjected to secondhand smoke. And when they're old enough to make decisions, we don't want them to choose to smoke because that would massively increase that individual's risk to develop MS. So Claire writes, my hand went numb in September of 2022. Excuse me. Excuse me. I apologize. I promise I'm not allergic to your question. So Claire writes, my hand went numb in September of 2022. At what point could I be sure I won't regain feeling? Let me take a sip of coffee and I'll answer your question. I look like I've gotten very emotional with your question. I just had a sneezing moment. Thanks, Claire, for your patience. So when you have an MS attack, it's caused by inflammation, and typically speaking, it will kind of intensify over days to week, and then it'll slowly get better over weeks to months, just typically speaking. And so after you take some steroids and recover from an attack, you may be left with some residual sensation or some residual deficit. And the question then becomes, well, when's it going to go away? Or if it's not going to go away, when can I feel rest assured that I'm stuck with it? That's kind of the question. I had some numbness in my hand. It's been about a year. And when am I going to be stuck with this? And that's a tough one. I would generally say that neurological symptoms after an attack that you're stuck with a year later are probably going to stick around. Even after 6 months, there's going to be less and less recovery as you move forward past 6 months. But I have been wrong before, and I'm delighted to share this story with you. And it just means that there is hope that sometimes things can change even though we don't exactly understand why. So the take home to your question is, if you're stuck with it about a year, I think you're probably going to be stuck with it. But I want to share with you an exception to that rule. A patient that I take care of, a guy who was kind of irritable all the time. He had a lot of neuropathic pain from his MS. His feet hurt really bad, and when he bent his neck down, he had electricity shooting down his back. And understandably so, he was a really grumpy dude. He wasn't very nice to talk to. And every time he would come to see me, so he'd come to see me every 3 months, and he would complain about the lermites, that when he moved his neck, he had electricity run down his back. He had had that symptom for over 7 years. And I would show him on his MRI how he had a big giant Goomba in his neck, and it made perfect sense neurologically that when he moved his neck, it would hurt. And he wasn't really into taking symptomatic medicines, so he didn't want to take the medicines to make this go away, but it really bothered him. And he kind of moved in block because he didn't want to trigger that pain. And it was really uncomfortable. Now, I gave him Lemtrada, that drug that I was talking about before, a really powerful drug. And he came back to see me 3 months after he got Lemtrada, and he said, "Doc, you're a liar," which is a weird way of introducing yourself when you come into clinic. He said, "Doc, you're a liar." I said, "Why am I a liar?" He said, "You're a liar because you told me this wouldn't go away, and now it's gone. You told me my feet wouldn't stop burning," and he's pounding the ground with his feet saying, "See, look, they don't hurt. I'm normal and you lied," which is wonderful. Now, I said, "You're right, I lied to you, but I didn't mean to lie to you because I was taught those things 7 years later couldn't get better." And he says, "Well, they did." And they did. And simply what that means is I'm not that smart, and we don't have all the answers in neurology. Now, generally speaking, if your hand went numb in September of 2022 and it's still numb in May of 2023, I'm concerned that you're probably going to be stuck with that. But as I point out in this example, sometimes we are pleasantly surprised. Thanks for letting me share that. Anastasia is zooming in from Crete, and that's really awesome. I would love to get to visit Crete at some point in my life. Hello from South Africa, yet another place on my bucket list. I would really, really like to go to South Africa sometime. Rose was diagnosed back in 2014. So Kay Samuel asks, does having repeat MRIs cause any damage? No, none at all. So the MRI uses a magnet, just like a refrigerator magnet, except a really, really powerful refrigerator magnet. And when you turn the MRI magnet on, it causes about 1% of all the protons, the hydrogen molecules floating around in your water, to stand up at attention. And then when you turn the magnet off, they fall back down. And then you turn the magnet back on, they stand at attention, and then they fall back down. And the falling back down is called the relaxation time. Different tissues relax at different rates. So fat relaxes slower than water, and it makes a different picture. And so then you get these pictures based on the MRI, the magnetic picture that we're taking. And exposing your brain to a magnet is not dangerous. In fact, we can do that in utero with a fetus. We can do an MRI. Now, when you give contrast, that is processed by your kidneys. And so the contrast can be a problem if you have kidney dysfunction. And so oftentimes we check kidney function before we would ask someone to receive contrast to make sure that we're not putting them at risk. Even so, it as well from Connecticut is saying, hello, howdy, hi. It's great to see you, madam. One of our amazing moderators is on. Thank you for that. So Marilyn asks, is it normal when getting an Ocrevus infusion to have a feeling of passing out or becoming confused or disoriented? No. And it says when the nurse gives liquid Benadryl. So this question is a good one. So when we give Ocrevus, which is one of the MS medicines, it's given in the vein. And we give what's called pre-medication. So we give you medicines to get ready for the medicines. It's like a stop ahead sign. You see a sign that says stop ahead, and you know that coming up, you're going to see a stop sign. So we give you pre-medications to get your body ready to receive the medicine. And one of the medicines that we give is Benadryl. Now, you can buy Benadryl over the counter at the pharmacy, pills of Benadryl, which you could take for itching or rash or allergic type stuff. When you give Benadryl IV, it's more potent. It hits faster, right? And it's not uncommon that when you give someone Benadryl, it can make them feel a little loopy. Now, they shouldn't feel like they're going to pass out or be confused, and I would definitely let my nurse know, hey, last time you gave me Benadryl, it made me feel really, really weird. But the Benadryl makes the Ocrevus better tolerated. Now, because Benadryl can make you feel a little loopy, my infusion center and my clinic pay attention to that, and I'll explain what I mean. Very often, we like to do an Ocrevus visit bundled with a clinic appointment and an MRI. So that's a really big day for the human being. They fly into Columbus or they drive into Columbus, they get an MRI in the morning, then they come to the infusion center, we get a vein spiked, and then they receive their Ocrevus, we show them all their MRIs, we do a full exam, we do a clinic visit, and then they go home. But the timing is important because if you have your MRI, you get in the infusion center, we give you Benadryl, and then I start to talk to you, that doesn't work very well because sometimes you can be really loopy. So we'll get the IV started, we have to do the clinic visit, show them their MRIs, then give them the Benadryl. I have a very, very dear family, a patient that I've taken care of for a very long time, a lovely gal. And before we put this rule in place, we had given her the Benadryl before I came to see her. Well, the problem was she was sleeping. So I'd try to wake her up and she was asleep and her husband would laugh and I came back and tried to wake her up and she's asleep. I never really got to talk to her that day. So the next time I saw her, she said, "Hey, mister, you never even came and saw me during my infusion." And I laughed and her husband laughed. And I said, no, I was in the room 4 times. You just don't remember because we had you completely goofy on your Benadryl. So we want to make sure that we take care of all the education, all the examination, all the review, all the chit chat before we give people Benadryl so that they're not completely out of it. Good question. So Sherry says that she ran presses prior to her MS. So maybe you used a press like that. So Sherry, if you know someone that would like to have a giant platen press, let me know because I certainly don't have a use for it here. All right, let me change up the scene a little bit. Ha-ha! Snapchat is in effect. So some of you like the Snapchat filters and some of you, I think, hate the Snapchat filters. I have to be very honest with you. It's really fun for me. Look at me. I'm a computer cartoon character. I don't know, it's just really kind of a fun time. Let's answer a question or two like this. Hopefully you guys don't get really upset with me. All right, so Jennifer asks, let me move this into the screen so you guys can see it. Are you familiar with CRPS? I have that in addition to MS. So CRPS, complex regional pain syndrome. So I am familiar with CRPS, complex regional pain syndrome. So complex regional pain syndrome is a really nasty phenomenon where typically someone will have some type of trauma, like a car accident or something. And maybe they get banged up in their arm, let's say. And subsequent to the car accident, they develop a pain syndrome all down their arm, which is disproportionate to whatever happened. So the car accident is over, all the injuries have recovered, except now their arm is in excruciating pain. And it can be very, very life-altering. CRPS is very challenging to treat. In a past life, I used to treat CRPS with some really strange drugs, this drug called Prialt. So sometimes nature is too generous and you can have multiple sclerosis and you can have CRPS. I don't think that they're related, but I'm really sorry that you have that. And I'm hopeful that you're working with a really good pain doctor or someone that can make it palatable. So Nicola from Paris asks a really good question. Why do you know why in France neurologists don't use Lemtrada? And I think I do know why. And it's not because French neurologists aren't amazing, because there are some really, really absolutely world-renowned MS French neurologists. I think it's because of the safety profile of Lemtrada. So since Lemtrada has been FDA approved and approved in the EU, we have seen cases of autoimmunity that have cropped up. We've seen rare cases of strange events that have cropped up. And I think that in the European Union, they've kind of clamped down on its use because of the side effect profile. Now, that's much to my chagrin because I still think that Lemtrada is the most effective MS medicine out there. I don't have more data than that. I'm not sure about the specific details. So, for example, I'm not aware that if under certain circumstances, a French neurologist can in fact prescribe it, maybe under extreme circumstances or something like that. Je ne sais pas exactement, mais ça fait un peu triste parce que c'est génial comme soignement. Et j'espère que si c'est nécessaire d'avoir l'entrada, on peut quand même avoir, je sais pas. All right, let's move on to another question. Cynthia is on. Hey, Cynthia, it's great to see you. Oh, we had talked about this a little bit earlier. All right, so here is a long time, where did she go? A long time viewer. Oh, I just lost it. This is really hard doing this all by myself, guys. I'm scrolling through this list. I don't know if you know this, but I'm dyslexic. And so looking at lists of things is really, really challenging for me sometimes. Elizabeth Murphy writes, let's get off this Snapchat filter in case you guys are throwing a fit. Let's do this. So this is kind of fun. So the question from Elizabeth is, I'm about to start Ocrevus tomorrow. This past Tuesday, let's see what it says. I met with a patient educator from Genentech. She helped me understand. So I'm feeling hopeful today. Well, that's awesome. You know, Genentech this past year here in the United States put forth a plan where they have trained nurses that will get on the horn with you and kind of talk you through getting ready for the medicine. And so if your neurologist isn't able to help you do that, the fact that they can do it is really, really great. Let's see, you guys can't hear the music. Can you guys hear the music? Hopefully you can hear that music. I can hear my dog snoring. All right. The Sirene writes, my husband's neuro couldn't prescribe him Sativex for his pain, no official protocol. So his physician agreed to fentanyl patches, which has given him a lot of relief from pain. Well, you know, fentanyl is a narcotic. I really dislike using narcotics in my own practice. I won't prescribe them. Now, I'm reading that your husband is benefiting from it, and I'm delighted to hear that. Laura is online. Wow, that's so awesome. So those of you that don't know Laura, she's an amazing gal and a huge MS advocate. Very, very involved in the MS community. In specific, does a lot of work with Can Do MS, which is a really awesome organization that she's involved in. So if you guys don't know Laura, you should. She has a podcast about diagnosing multiple sclerosis, which I really enjoyed listening to. Great gal. So here's one of our wonderful moderators pushing forth a question from Elizabeth Murphy. Look up No Stress MS. Yep, No Stress MS is a buddy of mine. Does a really, really nice job, makes some really funny videos. That's Damian Washington. I would definitely check him out. I like the guy a lot. He's out in California. Very, very funny dude. So here's a question from Kumar. Hi, doctor. Well, hello. Can COVID vaccine cause optic neuritis? A year back, my relative's 18-year-old, first optic neuritis episode 2 weeks after the COVID vaccine. Is it possible the vaccine induced optic neuritis, and could it be recurrent? That's a really, really good question. So vaccines can sometimes do things that we don't like. When you give someone a vaccine, you're trying to stimulate the immune system. And you're trying to specifically stimulate the immune system so that it can develop an arsenal against that particular bad guy, against that particular bug that the vaccine was created against. But when you trigger the immune system, sometimes it can get riled up. And in fact, there are some conditions that are cousins of MS. One is called ADEM, acute disseminated encephalomyelitis. I didn't make up that word, which is a pediatric condition, which is like a really bad MS, which can occur all at one time right after a vaccine. Now, that's not what we're hearing here. We're hearing someone had a vaccine and 2 weeks later had an optic neuritis. And what I would be curious about is if the vaccine sort of triggered the optic neuritis to start. Maybe this human would have had optic neuritis on their own, and we kind of sped things up with the vaccine. That's conjecture. We don't know the answer. Now, what I would need to do in that situation is we would need to follow that 18-year-old with serial MRIs over time in hopes that it was just a one-time optic neuritis. But if we see brain lesions that show up going down the pike, well, then we're going to be dealing with multiple sclerosis very likely. Now, I'm going to see if I can change my camera here just for a second so you can see my dog. River dog, come here. Sit. Good girl. It's a good baby. So right now, River, there's 164 people from around the globe looking at you. That's right, because you're a pretty girl. You're my pretty doggy. You good baby. Can you say hi to the internet? Say, hi, internet. I have stinky doggy breath. Mwah. All right, you can lay down. River is a work dog. She comes to the Boster Center for MS every work day, and she does her job very, very well. Her job involves going around to every single room in the clinic and asking for food. And I'll share with you that many of the gals that I work with have spoiled her rotten. So there's one of our expert billers, a gal named Beth, who is a rock star at helping navigate all the finances with patients. She does a really, really good job. And she's a very quiet, lovely gal, very, very timid, and kind of keeps to herself and does a very good job at work. And one day I'm walking down the hall and Beth's door is open, and there's my dog River, and there's Beth with a box of Cheez-Its, and she's feeding River Cheez-Its. And I said, Beth, what are you doing? She goes, oh, sorry, this is River's box. So my dog has learned some very bad habits at work because she's spoiled rotten, and I think she loves it. Even so, it as well likes when I said a big giant Goomba. All right, what else do we have going on here? DE writes, my non-enhancing lesions are getting less prominent between MRIs. Is there an explanation for this? Yes. So those white spots are areas of inflammation. And the white doesn't tell you whether there's demyelination or remyelination, whether it's getting more inflamed or less inflamed. It just tells you where it occurred. So if you have a new T2 bright spot, a new white spot on the MRI, it's possible that that spot is still, at the time the picture was taken, very active, and it was new, and there's still a lot of water signal because the inflammation is new. And as your body recovers and repairs, some of that inflammation will quell. It'll calm down. The water will be reabsorbed out of that spot, and the spot can actually get smaller. And so that's really great to see. I love hearing about that. Saskatchewan is in the house. I love that. That's really great. So Just Chrissy writes, it's official, Dr. B. Got my Ocrevus scheduled finally. Good job. I'm delighted to hear that. That's really fantastic. Hey, Dr. Aaron, Manitoba, Canada. That's awesome. Manitoba, Canada, for Americans, is way up north. It's a tiny little dot in around western Canada. I actually have a very good friend that I was an international exchange student with from Manitoba, Canada, a guy named Kyle Calvert. I haven't thought of him in 100 years. So here is a question. So this is really great to hear. Someone says, hey, I got better. I was in a wheelchair. Now I'm riding a motorcycle. That's really awesome. So Hillary talks about that electric shock, the Lermitz phenomenon. When you bend your neck down, you feel a zap going down your back. That's called Lermitz phenomenon. Jim P says, hello. Well, hello, howdy, hi, sir. Hope you're doing well. So Stacy asks a question. Good morning. I had the MS hug for the first time, but no new MRI activity. Can you explain that to me? So yeah, let's take this in two parts. What is MS hug, and how come I can have something and it doesn't show up on the MRI? All right, so those are two separate questions, and I think they're both very, very important. And before I answer them, I want to thank 165 of you that have jumped online on this lovely Sunday morning to spend some time with me. Thank you. So let's get into the question. What is MS hug? So the MS hug is a very nasty symptom where the human being feels like they're in a vice, or like that their bra is way too tight, or there's a lasso wrapped around their waist and someone's tugging on it and they feel squeezed. Oftentimes, when you first have MS hug, the human being feels like maybe they're having a heart attack or something scary and wrong with their heart or lungs because they feel this chest pressure. Now, what is actually causing the MS hug is interesting. Not in a good way, but it's interesting. It's a problem typically with the spinal cord. So we need to think about ribs. So many of you in the United States may enjoy eating ribs. Like there is an entire type of cuisine about eating ribs. I like to smoke ribs on my smoker in the backyard. And when you're eating rib meat, there's a rib, a bone, and then another bone, then there's meat in between there, all right? Now, in medical land, those are called the intercostal muscles. And just like a cow or a pig, humans have meat in between their ribs, these intercostal muscles. So if you just, while you're sitting there, take a deep breath and expand your ribs, and then contract your, squeeze your ribs together, the muscles bring the ribs together. Those are the intercostal muscles. And they are controlled by your spinal cord. If your spinal cord has a lesion, it can trigger those intercostal muscles to clamp the ribs down. They will contract the meat between two ribs and pull the ribs together. And literally, your body is being squeezed by your own body. And it's a very, very painful phenomenon. MS hug is super unpleasant and oftentimes associated with a spinal cord lesion. So that's what causes the MS hug. Now, your question is, how come there's no new MRI activity? Well, first of all, if you're only imaging the brain, you're not going to see MS hug because it's a problem with the spinal cord. And if you're only imaging the cervical spine, you're going to miss it because it's typically a problem with the thoracic spinal cord. Now, if you image the thoracic spinal cord and it's not complete contiguous cuts, in other words, if you skip some space when you obtain the images, you might miss the lesion. Now, let's pretend that you have MS hug and you get a thoracic spinal cord MRI and it's a perfect MRI and you don't see anything. Well, guess what? You still have MS hug. It's not true just because you don't see it on the MRI. So that's my second point, is that the MRI is a picture of structure, right? It's not the answer. It's just a picture of the structure of what's going on. You're a human being. You didn't make it up. You didn't invent that you had that. That's real. And just because the MRI doesn't show it doesn't mean it's not true. That's a great question. Thank you for asking it. So Boris says, do you recommend having checkup MRIs with contrast? So I do. If the human being is uncomfortable receiving contrast, then we don't do it. So if you say, hey, I don't like contrast, then fine, then we won't give you contrast. But I learn more information when I give you contrast. So I have more information to share. I can learn more about your MS if I give you contrast. I would submit that I probably learn 15, 20% more information with contrast than without contrast. Now, that doesn't mean that you have to have it. It just means that with it, we're going to learn more information. I would say that during the diagnosis, I think contrast is really, really important. So Jay asks, does antiviral drugs help with smoldering MS? We don't know yet. So Mystic Firefly, which is a pretty cool name, writes, I had electric shocks strike me in October. I was told that I have lesions on my spine. Still having tingling in my back on Copaxone. So thank you for sharing. All right. Kelly says, good morning, Doc. Good morning, coffee in hand. I hope that you're having an awesome Sunday morning. So Firefly is waiting to start Mavenclad. That's a great drug. So Lucy B writes, I've been on Ocrevus for years. My symptoms are getting worse. Is it time to start a new drug? And that is a really relevant question to talk to your MS neurologist about. We need to try to figure out what's getting worse. Are you having what's called PIRA, progression independent from relapse activity, and having some slippage despite being on the Ocrevus? Or are there chronic symptoms like spasticity that are simply not being well managed? And so I think that there's a discussion to be had. Now, there's 160 of you that have jumped online. I have a request. It's my request that if you haven't yet, that you sign up for the Boster Corner, our new newsletter. So if you're watching this right now and you would like to stay current on all the new, latest and greatest, please sign up for the Boster Corner. It's completely free. Just give your email address on that link, and then we will once a month send you an update to update you on all the new stuff that's going on at our center, my new videos, new research efforts, all those kind of things. And you don't have to be a member of the Boster Center to receive that. Sign up now. Go ahead and click that link and join us. I would love that. So Linda White says, worried about the cancer risk with Mavenclad. And so let's talk about that. So when we studied Mavenclad, there was a slight increased risk of cancer compared to being on placebo. And that risk, I calculate, was about maybe like a 1.4% increase compared to that general population that was compared to. And there was no pattern to the cancer. It wasn't like it was all breast or lung or liver or what have you. In fact, there was no pattern whatsoever. And the risk of cancer kind of tapered off after the first 4 years. And so what does the American FDA recommend? Very appropriately, they say age-appropriate cancer screening. We can keep you safe by monitoring. So when you're of the age of the mammogram, we need to do the mammogram. And when you're the age of the colonoscopy, whoop, you need to do the tube up the tush. We need to make sure that we're measuring, looking at your skin once a year and that we're feeling your thyroid. We need to do age-appropriate cancer screening. Now, if you have an active cancer, this might not be a good drug for you. But if you don't have an active cancer, I think it's on the table to talk about it. So we've got someone saying, hello, howdy, hi from Dublin, Ireland. I love that you're on here. Dublin is one of my favorite cities in Europe to visit. It's a fantastic place. I have spent several nights of my life tooling around Dublin, going from pub to pub and listening to live music. It's just a highlight of my life. It just warms my heart to think about those memories. Thank you very much for being here. So Hillary says that she had the MS hug and couldn't breathe. And it can be really scary because your ribs are tight and so it's hard to take a deep breath. It can be a very, very scary thing. We can treat MS hug. We can give steroids to quell it. We can even, under extreme circumstances, find an expert Botoxer to Botox the muscles between the ribs to relax them so that they don't do that. Now, not just any Botoxer can do that. You need a very, very skilled Botoxer because if they put the needle too far, they could actually hurt the lung. So we've got Norfleet in the house from Texas. Well, hello, I hope you and yours are doing well. Vermont is in the house. That's pretty awesome. No help for people with ADD who need energy. I don't think that's true. I treat a lot of people who have MS and ADD. Now, we use stimulant medicines very, very successfully to help them. Absolutely, no question about it. All right, I know that I've missed a bunch of questions. I'm going to kind of scroll back up here. So KG says no brain lesions at all, several lesions in the brain stem. So just to be very technical, the brain stem is part of the brain. And so when you say no brain lesions, what I assume you mean is you have no lesions at the top of the brain in the supratentorium. But MS doesn't have to abide by those rules, and you can meet criteria for MS having lesions in the spine, in the stem of your brain. That is possible. Let's see here. So this nice person says that they had ADEM. So I was talking earlier about this scary thing where oftentimes it'll appear in children, but it can happen in adults. It oftentimes occurs after an infection or a vaccination where you can have what appears to be a bunch of MS all at once, where the brain and the spine are affected. You have lesions that light up with contrast enhancement, and typically the person is very sick. They have multiple problems all at once. They're oftentimes hospitalized. Now, fortunately, they can recover from that. Now, just because you have ADEM does not mean that you'll go on to have MS. So this is an example of someone who had this ADEM picture and then later went on to have multiple sclerosis. Lauren writes in, can anyone recommend good ribs in New Jersey? VA girl appreciates it. That's really funny. So if you guys know about some good rib joints in northern New Jersey, definitely let her know. I'm of the opinion that you can buy ribs at Kroger's and cook them on your smoker at home, and they are delicious. All right, let's keep on keeping on. Let's look at Joan's question. Any thoughts on antivirals for MS treatment? Anecdotal reports of remission. So this is, reported by Dr. Giovannoni. So Gavin Giovannoni is leading the charge in his theory that MS is triggered by a virus, and it might be. It's still works in progress. So intellectually and philosophically, it's a shift of paradigm to get people to think that, hey, maybe this virus is triggering MS and maybe we can use antivirals to treat the disease. And there's still a lot of work and investigations. And he is definitely leading that charge. I think he would be very excited that you quoted him about that. This nice person, Nada, shares diagnosed in 2009. Biggest concern is fatigue and anxiety. My doctor prescribed modafinil, then Concerta for fatigue, and Prozac and sertraline for the anxiety. And This is a very, very common phenomenon where someone with MS has not just one thing going on, but they have multiple things going on. And so while we're treating the MS, hopefully we're using a disease-modifying therapy to slow the disease down. In addition to that, we want to treat symptoms. And so here we identify two very bothersome symptoms: anxiety, which is very common in MS, and pathologic fatigue, which is more common in MS. And so in addition to managing the MS with a disease-modifying therapy, we're going to use medicines to trigger the anxiety, and we're going to use medicines to trigger the fatigue, and hopefully the combination keeps the MS at bay. The disease-modifying therapy keeps the MS at bay, and then the symptomatic management helps with these two very yucky symptoms. I think it's a good example of how we treat the human being. So Boris says, thank you, keep the contrast thing in mind. So Terry says that her neurologist doesn't use contrast anymore, and I think many neurologists are avoiding contrast because if you have a kidney problem, then the contrast could hurt you. And the neurologist doesn't want to hurt you. So Adrian says, hey Aaron, can I ask any more news on the new B-cell medicine? So this is this BTK inhibitor that we've been talking about, and BTK inhibitors are currently being studied in clinical trials. They're actively being studied at the Boster Center for MS, which I guess my little thing's right here. At the Boster Center for MS, we are enrolling actively into these trials. We have, 40, 50 some people that are currently enrolled, and we are actively studying these compounds. Very, very exciting. All right, I am going to run and blow my nose so I don't sound so stuffed up. Please don't run away. I'll be right back and let's keep going. I'm loving your questions. Keep them coming. I'll keep giving answers. I just need to get a Kleenex. I'll be right back. Don't run away on me, guys. Oh, okay. All right, now I can breathe through my nose again. Sorry about that. Okay, let's look for some more questions. Mystic Firefly's got another question. Also, JC virus antibody positive. Wonder what this means. Any idea how we got it? So let's talk about that. So the human body has tens of thousands of viruses that live inside of us, and our body doesn't care. These viruses live in us, and our immune system just smacks them and beats them up all day long, and it doesn't cause infection. One of the viruses that the human body has very frequently is the JC virus. So half of adult humans over the age of 30 have been exposed to the JC virus. And we don't know how you get it. Probably someone coughs on you or something, and you get the JC virus, and you just beat it up, and it doesn't really matter. There are super rare circumstances when someone who has been exposed to the JC virus takes a medicine which suppresses their immune system in a way that allows the JC virus to become active in the brain and attack you, right? So just because you have been exposed to the JC virus doesn't mean anything unless you've been exposed to the JC virus and then you take a medicine like Tysabri. So Tysabri is a highly effective MS medicine which creates the Great Wall of China with the blood-brain barrier so that no immune cells can go from the bloodstream over into the brain. That helps MS a lot. But if you have JC virus and you take Tysabri, there's a small risk, and when I say small, I mean like 100th or 1,000th of a percent of that JC virus changing and becoming active in the brain and beating up your brain. That's an infection called PML. And so when we put someone on the medicine Tysabri, we have to check the JC virus. And if it's negative, then there's no risk. That's like saying if you've never come in contact with HIV-tainted fluid, you can't get AIDS. Well, if you're JC virus negative, that means that you have not been exposed to the JC virus, and so there's no concern. If you become positive, then it doesn't mean that you're not allowed to have Tysabri. It just means that now if you take Tysabri, there's a very small risk, and we can actually calculate that risk. Want to say hi to Mike Delta Victor. I hope you and your family are doing well out in San Antonio, Texas. It's great to see you tonight or this morning. So here's a story from Roger, newly diagnosed in October of 22 on Tysabri. Was in a wheelchair, but now walking. Using baclofen or gabapentin, still having some burning sensations. So that's a great story about someone diagnosed, got on an effective therapy, made a meaningful recovery from an early attack, yay, and using symptomatic medicines to help live their best life. I love that. Thank you very much. Linda White asks about low-dose naltrexone. Low-dose naltrexone has not been detailed studied in multiple sclerosis, and yet plenty of patients anecdotally report some benefits to various things. Now, low-dose naltrexone is not dangerous. It's not going to hurt you. And if you're going to try low-dose naltrexone for pain and it works, I think that's fantastic. And if it doesn't work, then you can definitely try a host of other things. Now let's see. How do we find a good MS specialist that might do telemedicine? Well, you're going to have to ask that MS specialist if they do telemedicine. You know, pre-pandemic, I did no telemedicine. Now, about half my visits are on telemedicine because if we can take care of something on telemedicine and I don't have to bring you into my office and expose you potentially to COVID or infection, then I view that as a really, really good thing. I want to talk about that for a little second, but first let's change the scene. And maybe we'll just Snapchat it up and we'll put on some other, yeah, here, that's kind of fun. Hello, I'm a cartoon character. Da-da-da-da-da-da. So how do you find a good MS specialist that does telemedicine? So you got to ask them. So I do telemedicine routinely with my patients in Ohio. And I'm very excited to share that at the Boster Center for MS, we recently obtained what's called a compact license, which then allows me to seek a license in another state. And so we're in the process right now of securing licensure in West Virginia and in Kentucky and in a lot of states surrounding Ohio and Texas and Tennessee and states throughout the union where I have a lot of patients so that we can do telemedicine with them and they don't have to travel for all of their visits. That's something that I'm very excited that we've just started at the Boster Center. And that allows us to continue to provide care via telemedicine for those where it's appropriate. That's really awesome. And Jen said that's phenomenal. Well, Jen, thank you very, very much. It's been pretty awesome. So Joshua writes, opiates work as a stimulant for me. Stimulants do the opposite. So that, everybody's an individual, Jonathan. And you got to work with your doctor to figure out specifically what works for you. I personally dislike narcotics and don't use them in my practice. So Matt Allen G says, speaking of Tysabri, could you explain the role of oligoclonal bands? I can, although it has nothing to do with Tysabri. So we can talk about what are oligoclonal bands. So if you look at the word oligo, that's Greek for a few. So not one or two, but not a bunch. So a few. Clonal bands are something that is part of a scientific test that you can do. Let me explain how this works. One of the questions when you're trying to diagnose someone with MS is whether or not there's an overly active immune response in the central compartment, brain and spinal cord. Is the immune system revved up? We're looking for inflammation in the central compartment. And so one way that you can do that is you can do an MRI and you can give enhanced contrast and see if areas light up in the brain or spinal cord. And if you see contrast enhancement, that tells you that there's inflammation in the central compartment. Another way that you can do that is that you can do a spinal tap and you can look at the number of immune cells in the spinal fluid compared to the number of immune cells in the bloodstream. We expect there to be a lot more in the bloodstream than in the spinal fluid. And the way that we measure that are something called bands. So literally you take some spinal fluid and put it in a well and some blood in a well, and then you run it out on a gel electrophoresis in a laboratory. It's like an agar gel, like imagine like a bunch of Jell-O, and you run this through it. And based on the molecular weight, how heavy the molecules are, they will move down the agar gel and stop, and they'll make a band where they stop. Those bands represent antibodies. And so we can count the number of bands. So if you have a few bands in the spinal fluid that you don't have in the bloodstream, then that would suggest an overly active immune response. And that's one of the things that we look for in the setting of multiple sclerosis. So Laura loves the filters and says she's proving that old neuros can learn new tricks. Thank you very much, Laura. It just kind of makes things a little bit more fun. Now, we've been doing an impromptu Ask Me Anything live stream now for just over an hour or so. And I want to thank all of you. There's 165 of you that have jumped online to spend some morning time with me. One of the big reasons that I jumped on today was I was very excited to share with you something new that the Boster Center is offering. And that's the Boster Corner newsletter. So if you haven't yet, do me a kind favor and sign up for the newsletter. You can click the link that I've put in the chat and fill out your email, and we will start to send you every month the Boster Corner newsletter. My name's Aaron Boster, and as always, thank you for learning about MS with me. I am so appreciative that 164 of you took some time out of your Sunday morning for an impromptu Ask Me Anything MS. Now, tomorrow morning, I'm going to be putting out my next YouTube video, so make sure that you check that out tomorrow morning at 6 a.m. It's a little bit of a contentious video, and so I'll be very curious what you guys think. And as always, until my next live stream or my next Monday morning video, I want you to be safe and take care. God bless everyone. Have a great rest of your Sunday. Bye-bye.